Okay, hello everyone, and welcome to the next session of the GCCHE Western Pacific Climate and Health Responder course. My name is Dr. Vyas. I'm a public health physician and Associate Professor of Public Health at the University of Canberra. I'm wearing another hat here today, which is as co-chair of a new network for climate change and health education run by CAPHIA, which is the Australasian Council of Public Health Institutions in our region. So, as you can see, lots of us have gathered to talk about this exciting topic, an important topic. And we have three wonderful speakers with us today. I will share my screen just for some introductory slides and to reorient us for where we are in this course and the schedule. Just bear with me. If someone could just confirm that you can see the full screen of my slides here.
Confirmed.
Thank you. So, folks, we're at session number 8. The topic today is health system adaptation and resilience in a changing climate. It's the 8th of April, and you can see all these wonderful partner organizations that have come together from Philippines, Australia, Singapore, and also importantly, 2 different regions of the Lancet Countdown. This is a very important initiative that brings together researchers and policymakers on counting down to 2030 in terms of important indicators of climate change and health. So we have the Asian region as well as the Oceania region represented here. As a reminder of the course objectives, it's to increase health professionals' knowledge, self-efficacy, and communication skills around climate change and health. It's to expand global workforce capacity, which is all of us on this call. And I can see there's upwards of 500 people on the call, which is amazing to see. And to build and strengthen an agile and informed community around climate and health, education, advocacy, and policy. As a reminder of the course schedule, you'll see we're at session 8 out of 10. You'll see me again. I'll be moderating session number 10, the final one. But if we just look at what the topics that have been covered, you'll see we started with some really specific topics around environmental hazards. So, for example, poor air pollution in week 2 or session 2, extreme weather events, typhoons and flooding in session 3, and so on. We're now coming to the part of the course in the final 3 sessions starting today with more of a focus on the health system itself. So today's around health system adaptation and resilience in the face of a changing climate. But then next week, we'll be talking about the health co-benefits of action on climate change across other sectors, not health. And finally, ending on a positive and empowering note of climate justice through the work that we do as health professionals in climate change. I'll come back to the learning objectives, and I know some of our colleagues who will present will refer to these, but let's talk about the logistics briefly. This is a 90-minute session. We have an expert lecture for about 35 minutes, and we have 2 case studies of 15 minutes each. And then we'll have about 20 minutes for Q&A, questions and answers. And we'll have a bit of a panel discussion with myself and the 3 speakers. So please save your questions for that and start putting them into the chat functions provided. This session will be recorded, and the slide decks and resources will be shared afterwards. As part of this course, attendance is automatically recorded during the live Zoom sessions, and there's some processes here. Importantly, the YouTube views will not count towards your attendance if you want the completion process for this course. There will be a certificate of participation for those who attend more than 70% of the live sessions, and there is a final exam as well with 25 multiple choice true and false questions. Okay, without further ado, let me introduce our 3 wonderful speakers. We have Associate Professor Zerina Lokmic-Tomkins from Monash University. We have Ms. Kelera Ollie, Climate Change and Health Advisor to SPC, the Pacific Community. And we have Associate Professor Veronica Matthews, Principal Research Fellow at University of Sydney's Centre for Rural Health. I'll introduce them in a little bit more detail just before they present. And this is my time to stop sharing. I'll read out Zerina's bio, and then I'll encourage her to share her slides as I do this. Zerina is the founder of Maternal and Child Health Climate Adaptation and Resilience Network, I believe she's a nurse by background, and she works at Monash University, where there's a whole hub of work. Zerina, I particularly liked in your bio how you explained that it was the 2019-20 Australian Black Summer bushfires that changed the direction of your work, and I'm sure you'll be telling us a bit more about that. I'll hand over to you now.
Thank you, Adi, for that kind introduction, and thank you to the organizers for the opportunity to speak to you today. As Adi mentioned, my venture into climate and health is pretty much dated with the Australian 2019-2020 Black Summer bushfires, and I'll certainly share those and many other stories that have actually prompted me in the space where I am today. So my job today is to talk to you about the health system adaptation and resilience in a changing climate, and I will do that from several different perspectives. But before I actually go onto that journey, I would like to acknowledge the traditional owners on the land. Just let me see and fix my slides. They're not wanting to move yet. Here we go. I want to acknowledge the land on which I live and work, the land of Wurundjeri people, the First Nation peoples here in Melbourne, Victoria, and to acknowledge their elders, past, present, and emerging. It's very important to me to acknowledge the First Nations in this country. It is an ongoing continuous culture of 60,000 years, and there's much we can learn from the First Nations in a context not just of climate and health and adaptation, but in all other things in life as well. So really, as Adi mentioned to you, my key transition from clinical nursing, education and nursing, but also cell biology and health informatics, I'm an interdisciplinary researcher, was through personal experiences of 2019-2020 Australian bushfires, as our family has found ourselves in New South Wales, Eurobodalla region, being impacted by these fires in many different ways. Really, that prompted a journey of actually trying to understand what the Australia's changing climate is like, only to realize that we'll have many challenges in terms of rising global temperatures, in terms of how our continent being impacted by very much dry, arid climate over time. We'll actually be seeing more natural disasters that will be increasing in frequency, duration, and intensity. And really, I probably should stop using the term natural disasters, even though we closely associate it with all things nature, and refer to nature hazards, disasters instead. Because when we talk about disasters in healthcare settings, we really are looking at it from its impact on the community and what that actually means in terms of preparedness, response and recovery, rather than looking at it from the nature cause, and also sort of assigning the responsibility to nature, because really it is human responsibility on what's happening with the climate. Many of you may not know that Australia on average has warmed up by 1.47 degrees already since this actual recording of the temperature started in 1910. And really that whole intensity of what's happened, not just in 2019 and 2020 Australian bushfires, but also with COVID-19 pandemic and the disasters that have occurred in this space before, signal that we really need to be thinking very hard, not just about the mitigation aspect in healthcare systems, but also the adaptation. So I'm sure that you will all know that when it comes to climate and healthcare in general, that healthcare has this dual role. On one side, it contributes 4.7% of the global emissions to that carbon footprint. But on the other side, it has this huge responsibility to actually care for the health of populations that we are caring for. So that means that in healthcare system, there is the need very much to review lots of things that we do as part of delivering standard healthcare, in how we actually reduce that carbon footprint, but also thinking through in how we actually improve the resilience within our systems themselves. And that actually means thinking carefully what adaptation means at individual geographical levels. So what it does mean for me here in Melbourne will be different to somebody in New South Wales, in Sydney, or up in Queensland, but also very different to Fiji, to Indonesia, to Malaysia, to China, and so on. And that means that each of us has to think very carefully about the actual location where we are, what these impacts will be, and what do we need to be thinking about in that whole systems thinking approach in how we adapt. And in this diagram here on the right-hand side, I've actually listed several different functions that we could be thinking about in terms of adaptation and mitigation. And these will be familiar to you already, because in many aspects, we have heard a lot about what the public health systems are trying to do to proof the buildings and to proof the workforce and to try and develop the policy that would actually support that adaptation. So when it comes to actual work that we do, I mentioned earlier that I'm an interdisciplinary scientist. I've started off as a tissue engineer and cell biologist, and then became a nurse and later on health informatician. And I have a small research team that actually looks at the impact of climate change on maternal and child health. And we are having a very broad definition of what health actually is in these settings. We're not just looking at it from the healthcare services point of view, we're actually also looking at it from the community point of view, from the healthcare workforce point of view. And also, how do we support that whole adaptation in a context of technology-driven solutions, but also actually non-technology-driven aspects? Part of this work is actually to be thinking very carefully of how we explain the vulnerabilities within communities. And I know that vulnerability is not the most popular term to use, but for the purposes of this particular presentation, I think we need to use it because it does lead us towards the association of where the weaknesses are within the system to try and identify how we actually fix and address that. So as Adi mentioned earlier, this whole session then leads towards learning objectives of how we link the work that we do with the work that you need to learn in your individual ways. And so what we need to sort of look at this concept is how through the work that we've done, we've actually addressed the vulnerabilities and adaptation assessments in what that means, for example, in context of workforce development. How do we actually identify critical risks that we need to be thinking about as we're supporting, whether it's a community or the institution or the workforce, to actually be able to foolproof what's happening in terms of extreme weather events and other climate-related events that are occurring in this space. Now, the other thing is also to actually try and identify what is the pathway that we want to be examining in the context of the care that we are delivering. And I know that globally this will be different. Healthcare systems have different maturity, different responsibility, different workforce makeup, and all these things you really need to understand quite thoroughly in order to be able to map it out specifically for your own location. And the other thing that I really want to bring to this discussion is that need for interdisciplinary collaborations. At the moment, when we talk about climate and health, we're constantly seeing doctors and nurses being put at the forefront. But the healthcare system is so much more than doctors and nurses. It does bring other healthcare professionals in, there's allied health, for example, but also all the people that make hospitals and systems work, starting from cleaners or janitors all the way to the CEOs of the hospitals. We need everybody on board to actually be thinking carefully about how we improve the system over time. I won't go through these definitions here. They're just there to meet the learning objective, but there will be concepts that I will be using throughout my presentation. And I think it's important that when we talk about climate and health in particular, that we are very clear that when we talk about sustainability, we are talking specifically about environmental sustainability rather than financial sustainability or building sustainability and so on. And when we talk about the risk management, what we are really thinking about is that aspect of reducing the risk of a hazard that might be impacting the system in which we work. I am hopeful that you are all familiar with the World Health Organization's guidance for climate resilient and environmentally sustainable healthcare facilities. And if you're not, I've put a link here and suggest very strongly that you read this. Now, this particular framework has a sort of like an overall approach to how we could look at the climate resilient and environmentally sustainable systems. The very first version of this framework was specifically focused on the climate resilient healthcare system and predominantly on mitigation. So it was actually really great to see that in the second iteration that they've actually reconciled the need to adapt and the need to actually preserve the environment, to sustain the environment as we are seeking the ways to actually become climate resilient. And really, the key components here is to look at these four pillars that you have, and that's the healthcare workforce, the energy use, which is the major carbon footprint producer, so to speak, then the actual infrastructure, technologies and products that we could be using in the systems to support them, and this other really, really important determinant of health, which is the water and sanitation hygiene services, and how do we actually care for the waste that we produce. I mean, if you just think about the operation for very simple procedures, for example, appendix, you would be thinking a lot of the equipment that is being discarded, particularly in the West, where we are not that good yet at transitioning from single-use products to reusable products. So all these things need to come together to be thinking, again, in that systems thinking way, how do we actually do this without losing the quality and the safety of patient care? And for this purpose, I actually want to focus particularly on the healthcare workforce pillar and technologies, which is in line with our digital health theme that we do within our work. So as you're starting to evaluate any system in terms of its adaptation capacity for the climate-related impact, whether it's heat wave, flood, or other nature-driven disaster or natural hazard disaster, you need to be thinking it in terms of what prevention would look like. What do you actually need to do to stop a certain event from occurring? With nature, there's very little we can do to actually stop the nature from doing what it needs to do. But there is a way of actually preventing, for example, the injury that might be associated to community. There's the also issue of preparedness. So what do we actually do to prepare for the events that are coming? Scientists tell us very clearly that the frequency, duration, and intensity of natural disasters or nature-driven disasters will actually increase. So the question then becomes, what does that increase look like? By working with climate scientists, we can actually model these things in a way that actually gives us a prediction of what this might look like in 10, 15, 20 years' time. So I would very strongly encourage you that if you have that potential to actually work with our scientists, that you indeed reach out and try to understand what does this look like for your region. And this is really important because a lot of things about climate is uncertain. And we know what occurs in a big global level, but when it comes down to the communities themselves, that uncertainty is more pronounced. So for example, at the moment we might understand what happens in the state of Victoria and Australia in general, but to understand what that means at the individual suburb level or even couple of suburbs level is a lot harder. So we need to be thinking about that carefully. And then of course there will be response that if you have done all you could in terms of prevention and preparedness, that there will be a response that would help that system recover. And the more you prepare, the more you think about the prevention, the more likely it is for this system to actually recover better than in previous disasters. So when that shock actually occurs, you have systems in place to support that recovery that occurs afterwards. So that whole component of looking at the healthcare facility resilience needs to come to understanding what the stress is from the environmental context, what is this likely shock to look like. So for example, in some regions it could be floods, in some regions it could be heat waves, but there are also of course other natural hazard disasters that you need to be considering. There will be many unique components to each of these disaster preparedness plans, but there will also be unique structures, for example, for flood as opposed to heat waves. And this becomes particularly important if you have to manage large technology aspects like electronic medical records that use a lot of energy and overheat. And if you have a heat wave outside, then the actual function of those EMRs could be impaired if your data centers are not cooled, for example. So you need to be thinking about those aspects as well. And of course, if you don't engage in any of these components, you're very much at high risk of collapse. And that means that the healthcare system is not going to be able to recover from the shocks, particularly if the shocks are repeated at a very frequent intervals. There are another two documents that you need to be aware of in terms of looking at what vulnerability and adaptation assessments look like. And in this context, you really need to be understanding who your key components are, who is the community that you need to be working with, who are the stakeholders that you need to be engaging so that you can have that participatory process, in which case you actually want to be making sure that the assessment you are making meets the need of that whole system that you work with. Now, we've talked about buildings a lot and the system a lot, but what we also need to understand is that in addition to the hazards such as heat and droughts and floods, and the exposures in terms of, what the system might be experiencing, we also have the community vulnerabilities to consider. So in terms of, the young and the old and in the middle, the gender related issues, the mobility, the access to care, all these things need to be considered. So as you look at the overall models of care within your healthcare systems and each of the clinics that you might be looking after, it's actually really important to think about who is this population and what's the access to care when there is a heat wave. Should you be thinking about restructuring the appointments, for example, for the people that are coming in? Or should you be thinking about developing a different model of care that avoids that exposure, for example, to heat waves or to floods? So what is this new way of practicing nursing or medicine or general healthcare delivery would look like if you have capacity to reimagine that within your own context, acknowledging, of course, the limitations of the geography and resources and so on. The reason why we focus on the workforce in this space is very much driven by the experiences of COVID-19. I don't know how many of you would have been in this space before. I can see there's 788 of you online, but I remember very distinctly that very first day when they told us that the COVID pandemic has reached the shores. I remember being in a classroom teaching first-year nursing students first week of their program. We knew nothing about COVID-19 at that point in time, except, there was one YouTube video from the US talking about the virus. And I remember delivering this lecture and thinking, these students are going to go and face whatever this pandemic brings. And how are we going to train them? How are we going to prepare them? How are they going to respond? How are we going to protect them from the exposure? What do we actually do in this space to make sure that they're going to be okay? And I remember that whole exposure of being in a lockdown, pretty much ours was the longest lockdown in Southern Hemisphere, getting up at 4 o'clock in the morning until 11 p.m., trying to manage the education for these nursing students so they can join the workforce to actually meet the needs of the pressures that were experienced by that system. And that alone had huge consequences for our workforce. We know globally that there are shortages of workforce, in particular countries. Africa here is highlighted in red. But we also know that COVID-19 itself brought a huge resignation, particularly in the Western countries, so that then there was a pool of migration of healthcare workforce from low resource countries into the rich resource countries, then causing further disadvantages and inequities in the countries from where that workforce came from, because now who was going to care for those populations? And so for us, really became really important to think about, well, what does it mean to prepare the workforce for climate change engagement? So when we talked about this other thing in terms of workforce itself, if you go back to that assessment of vulnerability, you actually need to be thinking about what is the risk that my healthcare workforce will be facing. Again, coming back to that unique geography requirement. Also, what the future scenarios might look like in this space. What is my preparedness of the workforce now? Like here we see that there's a lot of interest, but for where every one of you that are on the program now, there'll be many others who are not. So how do we prepare everyone in a way that actually makes them ready for whatever the future might bring? Acknowledging very clearly that climate change is a polarized issue and that how we communicate that, which was addressed in a few sessions before, becomes really important to ensure that we bring everybody on board. Then there is the organizational support. What is your organization willing to do to mitigate and adapt? And how much are they open to the feedback that comes through? Fundamentally, where things tend to fall apart a lot is that investment into workforce. Somehow we are always seen as the most expensive component of the healthcare system, and not the most crucial component. We hear a lot about investing into buildings and programs and very little into people. And I think we have to shift that narrative quite a lot, where people become the healthcare system and people really are the healthcare system. So investment into education and climate action is actually the path where we need to go. And the other thing that this means also is bringing that workforce into conversation of what environmentally sustainable assessment and response should look like. And how do we actually lead to evaluation refinements of everything that we want to do with the healthcare system? I do want to acknowledge that, at least this is my perception, that we are, as healthcare workers, we always asked to do more, always be at the front, always be advocates, always be everything. And we're not often given space to acknowledge that we are already tired. We are tired from COVID-19 pressures. We are tired from the past disaster responses and experiences. So how do we then work with this tiredness? How do we create workplaces that actually enable us to work with that, to move forward, to deliver the care, the quality of care that we really want to do? Acknowledging that there is a moral injury when the system doesn't respond to all the things we need to do the best we can to protect the communities we serve is a real requirement that needs to be moving forward. So how do you actually do that? Where do you start? And in this context, you need to think about two things. One is the existing healthcare workforce, which needs education and empowerment and voice to do what they need to do in a space that is comfortable for them, whatever that may look like. And then there is the new healthcare workforce coming through universities, through TAFE, for example, the enrolled nurse program, or community care programs, or whatever it might be existing in your country. And for this, you might want to adopt specific frameworks and specific approaches because they help you actually constrain the things you need to do. And so when you constrain the things you need to do, you have a much easier direction. You can actually figure out what the structure and consistency would be, what the education would be in comparison to what the practice is needed. And for this, we need better collaboration between academic institutions and healthcare systems themselves to support one another as we progress through. So in our program, we use planetary health framework. I know this is a very Western concept, but it is a really good one for us because it really ensures that we work as a system, one system within nature rather than separate human-driven system. I mentioned earlier that there needs to be a systems thinking approach, and that in this case, you really want to be thinking about complex system adaptive theory. So what does that actually mean? It's the simple acknowledgement that when we think about the system, is that we're not just looking at the interactions between the 2 points. It's that one single entity is influenced by many aspects. So for example, if you are a nurse, that means that you will be influenced by your undergraduate education, by the accrediting bodies that you actually need to apply for your license and maintain your license, by the hospital and the system in which you work, by the people you treat, by the people who manage you. So it's becoming really complex issue that needs to be looked at all perspectives. And what does this mean in terms of delivering usual care versus climate pressurized care? So in terms of disasters, in terms of heat waves, and so on. And when we look at it from the complex system adaptive theory, we need to recognize that every time we shift something within this system, there will be consequences. Sometimes those consequences are good, sometimes they're not good, and sometimes they're pure brakes on stopping everything from moving. So taking some time and thinking about this and mapping what this system looks like for you and who the key factors are that you need to be addressing becomes really important. So what would this look like in practice? So on this slide here, I actually have a complex system map, which we've used to develop the education for the climate change and health curriculum for nursing in particular. And here what you really have is the fact that when you want to develop a program that trains anybody, you need to be thinking about who your stakeholders are and who do you bring together. So here, for example, you might be thinking about the community input. What do they need? What does the actual accrediting bodies need? What the leadership wants, what does the health system want, what is the professional requirement for this, and what do you as a person think is important in this space as well. And then as you pull these needs together, you start to think about your own space and time and your own environment, your own geography, to then plan what that educational package might look like. So what is it that you really think they need to know? For example, teaching nursing students about that biodiversity is important to be aware of, but can they actually do much about it? Unlikely in terms of clinical care, but they can think about the fact of reducing waste production, for example, which would then have an indirect impact by actually reducing pollution to the environment, which then has, of course, impact on biodiversity. So all these things can be connected in a way that you decide what you teach people and how you teach it in a geographically responsible way. What it also means is that you can't teach people everything in one go. You need to scaffold that. You need to make sure that people can actually do this and to be able to be comfortable with that. So then when you start to implement this, you need to be open to feedback and to evaluation and what this actually might look like in tweaking these needs. You might think that something is really important, but if you haven't consulted with the community, it's highly unlikely that they will think that's important too. And when it comes to evaluation of everything that you do, you need to be thinking about, well, what is it that is your key outcome here? How do you know that your workforce is ready for the next stage? How do you know that they're disaster ready? How do you know that they are prepared to manage heat waves? How do you know that they can actually manage the different models of care that you are providing? So always have this whole picture in your mind as you're thinking about how this workforce development should actually work. This doesn't need to be very complex. We start with simple steps and we build that across the time. And I think this is really important. If you think about the climate change in its own right, it's such an overwhelming issue. But if you break it down into step-by-step process, you can actually see, oh, this is something I can do. This is how I can go about it. And find your tribe, see who is there around you to help you set this up so that you can meet the needs of the workforce that you are looking after. And for us, for example, one example here is looking at the case study where we have melioidosis as one of the examples caused by the bacterium Burkholderia pseudomonas. I probably didn't pronounce that very well, but it's an infectious disease that is actually affecting humans and animals, particularly in Southeast Asia and in Northern Australia. And as the climate changes, we actually see more of these cases where people are actually being impacted because they reside in soil and water, and it's actually endemic in some regions. So what this actually means then is that when we teach students about this, we need to be thinking about how is this actually linking back to climate? What do we want them to know about this? How do we want them to implement this in their practice? And really what it does highlight, it's a really wonderful example of One Health and planetary health in general, where you're actually linking everything in terms of the microorganism, the soil, the water, the human health, and then of course the planetary health itself. For more of these details, we've actually published this work before, so it should be possible to visit this as an open access publication. So again, all these examples are open to share, and please feel free to do so. In context of nursing, we actually got a whole group of nursing people together and we've developed the planetary health, climate change and sustainable healthcare framework, which we've shared with all the programs in Australia. Now, the next step for the nursing in particular is to talk to our accrediting body to make sure that planetary health is actually within the programs and regulated. So that means that everybody must teach it across the board. So adopting something like this might be important within your own space as well. And this can be adapted to medical programs, to community programs, and so on. Now I'm going to shift, in the last few minutes that I've got, shift the tact a little bit towards technologies. We do a lot of work in digital health, and digital health is often seen as a supporting technology that will solve all the climate problems. However, this is not the case. It's really important to recognize that digital health, only when designed with environmental sustainability and equity in mind, is actually supportive of climate change adaptation and mitigation. We know that the more we use AI, the more water we use, the more power we use. And we know that even simple things like emails and this particular conversation that we have impacts the carbon footprint. But in addition to this, we also have issues with e-waste and use of critical materials to actually make these technologies. So when we think about digital technologies, it's actually really important. By the way, I do have a positive bias to technology. It's really important that we do it in a way that is just, and that means just from all possible systems that we are looking at. So if you're looking at climate resilient healthcare system, and if you map your own system, this is, for example, a very basic map of a hospital related workload. We know that we'll have care aspects that are related to public health. We'll have, again, workforce development. All these processes are supported by technology. A lot of times when people implement technology, it's because it's nice, it's flash, it does these amazing things without asking the environmental questions. So we advocate a lot for asking, what is the environmental impact of these technologies? Can we design these systems in a way to reduce their energy consumption, to reduce their carbon footprint, and what happens in terms of recycling? So this also goes in terms of how we document the climate change impacts on health. We know that digital health technologies are present in epidemiological studies and surveillance and early warning systems, in risk assessments, pretty much everywhere. But what we know is that when we think about the supporting aspect of digital health is that we don't have the actual ways of documenting this. So one way that we actually looked at this in terms of electronic medical records is to map the United Nations disaster risk reduction profiles to SNOMED CT, which is a clinical terminology used a lot across the world in about 90-odd countries. And surprisingly for us, when we mapped the disaster hazards to this clinical terminology, we identified that pretty much all meteorological and hydrological and environmental components were missing from this. What that meant is that if you as a clinician wanted to enter this in electronic medical records, there was no possibility of doing this. So our mapping, we actually, when we did it and published it, we actually went back and said to the SNOMED CT company, well, you're actually missing these components. How are clinicians going to document this? And how do we know that epidemiological data that we actually look at is going to be accurate if we're looking at bedside to bench sort of aspect of climate change? And so we were very fortunate that the company actually responded to this feedback really well and decided to implement 90% of these recommendations so that people across 90 countries, for example, would be able to document the climate change impacts on health. So that means that there is a really good component and a way to be able to now use technology to do this. But on the other hand, we haven't resolved the e-waste issue, where, for example, a lot of our waste is exported to impoverished countries, where often there is a lack of policy to do this in a way. So really, particularly those of us in the West need to think very carefully about our responsibility. Well, how do we actually support these countries to engage in recycling processes to be able to do this in a way that is sustainable and they can provide a meal on a table? In this very last slide, in terms of technologies, there are a few tips for you there in how you can actually reduce your own digital carbon footprint. But I know that my time has run out and I will pass it over to Adi, who will introduce our next colleague from this speech. Thank you very much for the opportunity to talk to you today. Bye for now.
Thanks so much, Zerina. What a wonderful overview of the breadth of what we have ahead of us as health system practitioners in one way or another. And I quite liked your digital health spin at the end as well, because yeah, it's very easy to think that we're having a not very high carbon emitting experience here online. But actually, as you say, data centers and the cloud and the infrastructure of the internet is very carbon intensive. So thank you
Indeed.
very much for this. We'll come back to
Thank
some
you.
of that on the panel discussion. I might now introduce our next speaker, and I will bring up her biography. Um, it's a great pleasure to introduce to you Ms. Kelera Ollie. She's the Climate Change and Health Advisor based at the SPC, which is the Pacific Community, a grouping of Pacific countries that come together for policy and practice and action. And as you can imagine, the Pacific has been and continues to be a really key driver and a key advocate for climate action with lots of historical gains. Kelera has practiced environmental health for more than 20 years and specialized in communicable diseases, vector surveillance and control. And she's specialized in climate change in particular within that. I will also say it's been a personal pleasure to work with Kelera in the recent past to develop Fiji's Health National Adaptation Plan, which I think is one of a few things she'll be giving us a case study about. Thank you very much, Kelera, and over to you. We can see your slides. Go ahead.
Thank you, Dr. Adi. Thank you, ladies and gentlemen. Bula vinaka and warm Fijian greetings from Suva, Fiji. I have been introduced, so I will not take up my 15 minutes introducing myself. Sorry. Okay. So the title of my presentation today is Building Climate Resilient Health Systems Through Adapting International Instruments, a Fijian case study. And on that note, I would like to also acknowledge the organizers and the speakers for this course. And I also thank the participants who are tuned in online today to hear the case study that I will be sharing about Fiji. And I would also like to acknowledge my Fijian colleagues who are tuning in today, joining us on this presentation, and particularly the team that is conducting Adaptation Intervention Survey in the Northern Division. This is your story. And I would also like to stress the importance of the lecture that we have just heard. And my case study sits or is a small portion of what she had shared explicitly to us this afternoon. So the principal message in this presentation from the Fijian case study is that international instruments such as agreements, commitments, initiatives, the guidance and protocols that we have seen on her screen, and other things are useful only if climate change and health practitioners or health professionals efficiently or effectively, competently contextualize these resources into national and local cases. And I hope that this story of Fiji's case study will demonstrate what the message I intend to share with you entails. So you can see from the picture here that Fiji is located in the Pacific region, and it is made up of 332 islands, of which approximately 32% are permanently inhabited. So furthermore, the climate that we experience here in Fiji, it is a tropical country with two seasons known as the warm, wet season and the cooler, dry season. Fiji climate is driven by the mentioned climate events that you can see on the slide. And this means that the country experiences hot to warm weather almost all year round, with minimal temperature extremes, but that is also changing for us. It is getting hotter as well, and variable rainfall slightly higher in the warm months and certain parts of the islands. So, though Fiji contributes minimally to global greenhouse gas emissions, this small island developing state is vulnerable to the effects of climate change and already experiencing these hazards, which I have listed here. These are no longer projected, but we are living it now as we speak. And as I have said, we have increasing temperature, depleted fishery stocks, ocean acidification, more intense tropical cyclones we have been experiencing in the islands, shifting wet and weather seasons, and extreme dry and rainfall days that result in either flash flooding or expected flooding, and also prolonged dry weather when there's extreme absence of rain. And for sea level rise, it's also causing a lot of problems with our small islands. We are faced with coastal erosion, higher stormwater surges, there's water contamination, and also our populations living along the coast or riverbanks and the infrastructures have to be relocated or displaced. So these are some of the documented impacts of climate change on health in Fiji. And we have both direct, indirect, and also the long-term impacts of climate change to health. But the listed ones are those that we have experienced or those that have been documented for our local situations. So we have trauma, drowning, and injuries and deaths as a result of extreme weather events. We also have damages to our healthcare facilities and so as other infrastructure that is associated with the facilities. Water security and food security and safety are both compromised. We have seen increasing waterborne diseases and so as food-related diseases, including malnutrition and other nutrition-related conditions. There is increasing increase in vector-borne and zoonotic diseases. We all have also observed disorders of the eyes, ears, skin, and other body systems, as has been mentioned. And there's also observed influence on the mental and psychosocial health. And of course, our non-communicable diseases trend have been associated with some climate variables. And this is placing a lot of pressure and challenges on our health systems. And this list that I have displayed on this slide, this is the heart or the core of climate change and health work in Fiji. When we are strengthening our health systems to be climate resilient, we are addressing risks arising from the climate impacts that exacerbates the climate, these conditions for health in general. For us, we may collaborate, integrate, operate, all towards protecting the health of our populations. So now you have seen most of these, or maybe all of these documents or instruments that are on the slide right now. And as the previous speaker has mentioned. If you haven't, then you have to search for these documents, and I have given some links here on the slide for you to access and also familiarize with. I will not go into all these documents, but there's one there on the right that has already been covered on climate resilient and environmentally sustainable healthcare facilities, which I will be highlighting in my presentation. And also on the top left, you have the UNFCCC COP16 in 2010 established the process to formulate and implement national adaptation plans. This also gave rise to WHO's guidance to protect health from climate change through health adaptation planning. You can see that in the middle, and this was published in 2014. It was developed to ensure that the health sector works with partners in a systematic process to building health resilience to climate change. And also an example of this would be through the national health adaptation strategies that some of us have developed for our countries. And in 2015, here at the bottom, you can see this is the operational framework for building climate resilient health system, which was reviewed in 2023 to include low carbon health systems. And in 2021, you'll see on the left, Fiji committed to COP26 Health Initiative, also known as ATTACH now. And Fiji is one of the few, I think maybe 2 or 3 countries from the Pacific that is affiliated with ATTACH. And the WHO guidance for climate resilient and environmentally sustainable healthcare facilities is one of the documents that has accelerated or prompted Fiji's momentum in increasing resilience of health systems to the impacts of climate change. And from those international guidance, commitments, and documents, Fiji developed contextualized plans, policies, and even we have a Climate Change Act of 2021. These were all produced or reproduced to protect communities and our populations from the impacts of climate change. The health sector, guided by WHO documents and GEF or Global Environment Facility funded PCAF project, which is Piloting Climate Change Adaptations to Protect Human Health project, we started developing our own guidance and to build our climate resilient health system. So if you see on the right, this might look familiar to some of you. We have Fiji's own adaptation plan, Fiji's climate change policy, Climate Change Act, which I have highlighted here in the middle some of the clauses that cover health or environmental health within the Climate Change Act. And within the national adaptation itself, health has been quarterly given a chapter covering health adaptation actions. And contextualizing to the Ministry of Health or the health sector, in 2015, 2016, a climate change and health strategic action plan was developed, and that has been reviewed and upgraded to Fiji's health adaptation plan. I will talk about all these documents later. And we also developed or contextualized a guide for climate resilient and environmental health healthcare facilities. And I will say crash when I refer to this later. I think this has already been covered. At the outset, Fiji is being guided by WHO's definition of Health National Adaptation Plan. And for the 2016 to 2020 Climate Change and Health Strategic Action Plan, if you view the table of content that is on the top right, you will note that this is guided by the framework for building climate resilient health systems and low carbon health systems. So while the CCHSAP was developed to sustain the progress that Fiji had achieved since 2011 in the PCAF project that I had mentioned, the plan also promoted the climate change and health work that was being carried out in Fiji, and also attracted development partners and donor agencies. And this resulted in the continued support that came from WHO, the Korean International Cooperation Agency support that was given. And from this fund, we were able to develop the guidelines for crash CF and also implement some interventions to improve our resilience and our carbon emission. And in addition, it also guided the health chapter of the NEP process for Fiji, since climate change and health plan was already being implemented for at least 2 years before Fiji actually developed its national adaptation plan. And at the bottom right, you will see the achievement or progress evaluation of what the CCHSAP had achieved. It's also reflected in the new adaptation plan. And this is the story about the Fiji Health Adaptation Plan, which was launched at COP29 in Azerbaijan. There are 3 main phases. Oh, and by the way, it was Dr. Aditya who supported Fiji in developing this adaptation plan, and I acknowledge him in what I have here in front of you and presenting to you today. So there is an establishment phase referring to the climate change and health strategic action plan, where the focus was on climate sensitive diseases and raising awareness of climate change and its impact on health. And we had come through this establishment phase. We know that Fiji health sector and our counterparts and our partners familiar with this phase. We have moved into the enhancement phase, which is a shift towards climate-sensitive health outcomes. And we are also mainstreaming climate action across other health sector programs. And then we also have an excellent phase, which is 2023 to 2030 HAP and beyond, looking at a climate-resilient health system that can deliver healthcare services to international best practice, as you have heard in our previous presentation. Very briefly, on climate change, on guidelines for climate resilient and environmentally sustainable healthcare facilities. The idea to develop this came from the need that we needed to respond to some of the international, regional, and national documents that we have in Fiji. Excuse me. So component 6 of CCHSAP says that climate resilient and sustainable technologies and infrastructure. And then we were also responding to WHO's operational framework for building climate resilient health systems with the low carbon inserted now. And Fiji's Green Growth Framework 2014, which aims at reducing carbon footprints at all levels of the country. We acknowledge that our emission is negligible, but for us in health, having a healthy environment is also part of our work to promote. And we also have the Pacific Islands Action Plan on Climate Change and Health 2018 that promotes building climate resilience of our healthcare facilities. The guidelines also assist the Ministry of Health and other health sector stakeholders to include crash CF into the full cycle of healthcare capital works. And we are also supporting our proven leadership in the area of climate change in the past. And this is from LDCs and also small island developing states. You have seen this, so I will not spend much time on this, but that again is also contextualized to our Fijian context. So that same guidance is currently used to assess the vulnerability and the climate resilience of our healthcare facilities. We have two separate assessment phases within these guidelines. The first one you can see on the right side. It is the climate hazard and vulnerability assessment tool, where we identify and prioritize healthcare facilities for interventions to improve their resilience. And the second one is using the checklist that you would have seen in climate resilience in the CRASH CF guidance. So for Fiji, we have completed the first round of assessment of 211 healthcare facilities, not all, but I think we are just maybe 4 to 5 short of getting 100% of this completed. And this was conducted between 2021 to 2022. And as of now, the vulnerability assessment and that tool has been contextualized to be used for communities. So the achievements, very briefly, through these guidelines, we are currently implementing intervention strategies with support from partners like WHO, COICA, JICA, SPC, and other partners that we have here in our region. And we also have 10 healthcare facilities that are currently being monitored under the CRASH CF guidelines. And we hope that we will continue to implement interventions, both adaptation and mitigation in these healthcare facilities to increase resilience and environmental sustainability. And we are not without challenges and barriers. We have a lot of challenges and barriers here in Fiji, and I have a few here in front of you. Not in any order of importance, but I would say the most important one would be finance. Finance is our major challenge and a barrier of progress here in Fiji. So that it's both the absence of allocated national budget for climate change and for the CCH plan, and also the lack of information of funding opportunities. And where there is information on funding opportunities, we lack the skill or the competency and commitment to prepare and support proposals or concept notes. And in addition to the complicated or complex processes and templates that some of our climate financing institutions have. So, and this also affects us in that we do not have a dedicated position to implement and monitor climate change and health collaborations or initiatives and activities on the ground. We still have project positions which are not permanent. So next to finance, I would say maybe networking is weak in the country and in the region as a whole to share experiences and success stories, and also communicating climate change and health work is not does not have a focus at the moment. And in the Ministry of Health and in Fiji, climate change and health work is vertical or siloed in environmental health. And we also do not have much support in research data and information for us in Fiji. So future plan, very quickly. I don't know if I'm running out of time. Sorry, I'll just put this up as the future plan that Fiji is looking at. It's guided by the commitments, it's guided by the initiatives, by the resolutions from all international and also here in the region. And you'll see that HNAP, or the Health Adaptation Plan, is also there, and so as vulnerability assessment. And these are local instruments or national instruments that guide future plan and the progress of climate change and health work in Fiji. Thank you. And sorry for going overboard, going over time.
Totally fine, Kelera. Thank you so much for that wonderful presentation. And I really do want to emphasize to everyone that Kelera is presented in such a polite and sort of maybe even too humble a manner of a really important journey that Fiji's been on as a country and as a small group of practitioners in climate and health. You saw those slides with a number of normative international documents, which were then translated into the local context for Fiji. Not only that, they were then implemented on the ground through these really painstaking and detailed audits of health facilities, which is that CPHEA, Climate Hazards Vulnerability Assessment. So we'll hear a bit more about that in the question and answer session coming up shortly. But before that, we have the wonderful Dr. Veronica Matthews, who is a Principal Research Fellow based at the University Centre for Rural Health at the University of Sydney in Lismore. She facilitates community-led research embedding First Nations knowledges and rights as the original custodians to revitalise holistic healthcare systems centred on country. She has a background in ecology, environmental toxicology, and primary health systems. And she's also, importantly, the co-lead of the Indigenous Knowledges theme of the HEAL National Research Network, Healthy Environments and Lives. And it's been a pleasure working with Veronica through that mechanism. Veronica, over to you for the next 15 minutes. It'd be great to hear about your work. Thank you.
Thanks, Addy. And yes, pleasure's mine in terms of our collaboration so far. I'd like to thank the Columbia Consortium for this invite today to present this case study, which is focused on a new chapter that we published last year in the National Preventative Health Guidelines for Aboriginal and Torres Strait Islander people, who are the First Nations people of this continent that's now called Australia. It covers the same themes that Zerina and Kelera have just presented on in terms of health professionals thinking about risk mitigation and adaptation advice for community members as part of their healthcare, as well as thinking about reducing carbon emissions at an organisational and personal level. It's very much, though, from a primary healthcare perspective, so I'll make that point, but I think the messages are relevant to other health sectors. I would firstly like to acknowledge the traditional custodians of the lands and seas that make up Australia. And I pay respect to elders past and present for their careful custodianship of this country, and also extend that respect to custodianship across the globe and any First Nations people on the call today. So I think the rationale for placing a climate change chapter in the National Preventive Health Guideline would be clear to you all. I'm sure it's been well covered in this course so far, that climate change is having a number of direct and indirect impacts on the health of communities, especially First Nation communities who have contributed at least to global warming and also have minimal resources to support adaptation. So Kelera has already talked about the direct and indirect impacts of climate change. It's similar for First Nations communities here in Australia. However, climate change does have a disproportionate impact due to the high level rates of chronic disease that are already there in our communities due to colonial injustice. For example, extreme heat and bushfires that are worsening cardiovascular disease and respiratory disease levels. The loss of land, the loss of homes, community infrastructure from sea level rise, from intense cyclones from more severe flooding. The sense of loss triggered by seeing the land sick, so traditional lands sick, affects community well-being and mental health due to First Nations' close traditional connection to country. And then these direct impacts then indirectly affect availability of food and water resources, the spread of vector-borne and other infectious diseases. And extreme weather will also compromise First Nations' ability to carry out their cultural responsibilities in caring for country, which means with that restriction, ecosystem degradation will be compounded, and also the social and emotional well-being of communities. Extreme weather events can also disrupt the very services designed to support communities through crisis, through impacts on health workforce and infrastructure, and that's why we're here to talk about today. And on top of all this, existing socio-economic conditions compounds the impact, things such as poor housing, lack of reliable electricity, and inability to shelter safely from extreme weather. So these impacts have been laid out in this discussion paper a few years back, which is a collaboration between the Hill Network and the Lowitja Institute. It's based on a scoping review and a roundtable with community leaders that are on the front line of climate change impact. The link's there, and I encourage you to have a read. So climate change is seen as an extension and exacerbation of ongoing colonialism, as described by this community member during a climate change inquiry in WA. Climate change is a continuation of past disruptions that have seen our mob, our community, lose land, interrupt their culture and sense of community cohesion. And I've just placed here 3 examples, again, different geographic and climate contexts, as Zerina has pointed out. So in Bunjalung country in Lismore, where I live, we've had 3 major floods in 5 years, with the latest flood only a few years ago, 2 metres above the previous record. And 3 years on from that event, scars are very much present. Many local residents are still living in limbo, not being able to return home, including the local Aboriginal Cabistry Island community. Many are still living in temporary pod villages. And so there is still a long road ahead in terms of finding housing security and certainty. Sea level rise in Zenith Kes, or the Torres Strait Islands, that are washing away lands and livelihoods, and also the increasing intensity and duration of heat waves in the centre of the country at Tennant Creek, Warramungu country, matched with poor quality homes and thermally efficient homes that do little to protect the community there. And I'll come back to these examples a bit later on. So climate impacts, again, vary depending on community location, but all lead to worse health outcomes if not properly prepared and resourced. So this is what we've attempted to do with this guidance for primary healthcare, for general practitioners and other primary healthcare professionals, and what they can do to help their community and organisation prepare. There is a responsibility for healthcare professionals to practice with a climate lens, learn about climate change impacts, and assist patients prepare to avoid the adverse health outcomes that are there already from climate change. This is the structure of the chapter. To develop the guide, we reviewed current evidence related to preventative measures against climate threats. And from this evidence, we developed recommendations and tips at 4 different levels, what we call the 4 domains of influence. What can be done within the clinic or at the practice level? What can be done at the organisational level? What GPs and primary healthcare professionals can personally do in terms of walking the talk. So modelling behaviours that are healthy for body and spirit, and also healthy for the environment. And advocate for patients at a broader system level for change to improve their own, the patient's capacity for climate adaptation. There's also a resources section that directs primary healthcare professionals to helpful tools and resources. So the first level at the clinic practice level, again, get educated about climate change, how it can harm health, then understand the patient context, where they live, how well resourced they are, do they have climate sensitive health conditions. Knowing that context means understanding their risk and then allows you to give the right and appropriate evidence-based advice. So this table, which is also in the chapter, summarises some of the characteristics of patients that may place them at greater risk in terms of where they are in their life course, what underlying illnesses they have, what medications they're on, and so forth. And whether they have social connections to draw upon during disasters, and whether their jobs or pastimes place them at higher risk. And so consideration of this risk should occur during annual health checks or opportunistically, especially when there is extreme weather forecast. And to help with this, flags can be added into patient information systems to highlight risk and link to seasonal recalls as a reminder for professionals to have these climate and health discussions. So once you have this understanding the patient context, work with the patient to design the preparation strategies that are suitable for them to reduce their risk. So you'll need to consider things like patient access to emergency communication. So in Australia, that would be agencies such as the State Emergency Service, the Bureau of Meteorology, who regularly give out public health advice such as heat wave warnings, flood warnings and air quality alerts. Patient access to friends and families they can turn to for assistance during a crisis. Patient access to resources for essential items and services. For instance, do they have the medications to see them through a extreme weather event? Do they have the ability to store heat-sensitive medications appropriately? And do patients have access to alternative power supplies in case of blackouts? But it's also important to note that best practice recommendations are not appropriate for all. So, for instance, some households don't have ready access to finances to run air conditioning. That top photo there in the slide is an example of a remote house from Tennant Creek where an elder lives. There's no electricity, there's no insulation. It gets extremely hot during summer. So advice from a health professional needs to be more nuanced based on the patient's level of resourcing and their context. So we do strongly recommend to GPs to talk to the patients about their housing. You know, is there crowding? Is there access to reliable energy, refrigerators, other cooling devices to assess patients' ability to shelter appropriately? And if necessary, and this is where advocacy is so important from health professionals, to work with community, to work with researchers, to join a team of advocates to make change. And this is the middle photo there is Dr. Simon Quilty and Uncle Norm Japarula Frank from Tennant Creek. Dr. Quilty has been a strong advocate for community in Tennant in relation to access to renewable energy and rooftop solar. So a lot of the majority of Aboriginal community homes or households don't have access to renewable energy like the majority of Australian households do. It was a well-publicised campaign which got the Northern Territory government to facilitate connection for Uncle Norm. It took a number of years, but we got there. However, 3 to 4 years after this campaign, Norm is still the only community house in Tennant with solar. So this advocacy still has to continue. And I take Zerina's point that health professionals are tired, but so are community and so are researchers. But if we work together, we can make change. So just to make a point there about Uncle Norm, he's on renal dialysis. So it's so important for him to have that regular energy connection for his dialysis and for his medication. And it would be so nice just to be able to extend that benefit to other communities. So when also talking to patients, think about co-benefit strategies where appropriate for the health of patients and health of country. So active transport also improves physical health and air quality, promoting healthy diets, high vegetable fruit intakes, less or no red meat, which contributes to lessening the carbon emissions. Also vaccinations for the increased range and occurrence of vector-borne and other infectious diseases. At an organisational level, prepare the service to provide safe, high-quality service during disasters. So this goes back to what Zerina was talking about earlier on. So I won't pay a lot of time on this slide, but think about your infrastructure and workforce capacity. Perhaps you might need to have a surge workforce immediately post-disaster for mental health issues such as PTSD. Be an integrated service, so work across sectors, participate in local disaster and emergency preparedness, and also advocate for First Nations communities to be part of that planning process. And be a greener service, as Zerina has just covered. At a personal level, walk the talk, think about environmental sustainability in all clinical decisions to reduce medical waste and carbon emissions. Role model environmentally friendly practices, so, you know, walk or cycle rather than drive. Join an advocacy organisation. So here in Australia, we have Doctors for the Environment and the Climate and Health Alliance. At a broader system level, again, it goes back to that advocacy. Medical professionals are so well respected and have played a crucial role in previous successful public health campaigns, such as tobacco. So I really encourage you to lend your voice and advocate on issues outside of the control of community members and households. So just going back to the Warramungu example in Tennant Creek, I wanted to finish on this slide because it really demonstrates the power of local community action when it comes to disasters. You know, we've got Willie Junta, so the community members there in Tennant Creek actually designing their own homes. In Lismore, you know, the local Koori Mau, which is Indigenous owned, stood up and really led the community response. And in Torres Strait, you know, with the Torres Strait 8, who took the Australian government to court to the UN and won in terms of the Australian government negligence in terms of really ensuring that the islanders are protected from climate change. So I think I'm out of time, and I'll leave it there. So thank you very much.
Thank you very much, Veronica. Clearly, frontline issues, as we often think about our colleagues in less well-resourced part of the system, whether we're thinking internationally or regionally, like in the Western Pacific, but also, as we say often in Australia, right here at home. But thanks for sharing these insights, and quite sobering insights too. Now, folks, we have about, let's say, 15 minutes or so for a panel discussion and question and answers. We won't get time, unfortunately, to go through every single question, and I have been looking at them. They're very interesting and quite detailed as well. So thank you all for your engagement. Just noting that we hit a peak of about 800 participants on this call, which is wonderful to see. So, Kelera, if you'd like to also come on video, it'll be the four of us, and we will have a chat about a few questions. Maybe to start, a question for our panelists. Was there anything you heard from one of the other speakers that you have at the top of your mind that you'd like to pose a question? If you want to do that, let's do that, and then we'll go to the questions that participants have put to us. I'm seeing a pause, so I might go to the list of questions, which is totally fine. Zerina, maybe we can start with you. There's a lot of talk here. For example, there's a question around, we see a lot of potential of AI, artificial intelligence, and new technology. In this case, how can we build them into zero carbon and resilient cities? But I think we can also expand that question to say net zero health systems. So maybe if you'd like to focus on the health part of it and tell us how we might incorporate all these innovations in digital health and AI in a climate sensitive way.
So there's two components to AI. There is that one of infrastructure, which is basically what it uses in order to be able to deliver the advice, if you like. So we're looking at the structure of the data centers, the amount of fresh water being used to cool those centers, and also what's actually being used in terms of technology to build them. So it is actually possible to look at the back structure of the AI to design algorithms in a way that actually minimizes the energy consumption. It can also be possible to obviously switch to renewables so that if there is an energy consumption that comes from a renewable source rather than fossil fuel, there's also a way of how we connect specific technology units to minimize the expansion of the energy that occurs in that space. So there's that component. But then there's also the component of what AI itself does. So you know that AI output is only as good as the data that it has. So how do we ensure that the data that enters AI is equitable, that it's actually documented correctly, that it acknowledges social determinants and environmental determinants of health? So if we think about these things consciously and design it in a way to deliver that intervention, then it is possible to have environmentally sustainable AI. What worries me at the moment is this propensity to just hop on and use AI without thinking what it actually does in the background and what cost it has to the environmental sustainability.
Thanks, Zerina. Great answer about the different arms of what we should consider across digital health innovations. Veronica, I wondered, do you have any comments on that? Because often we hear about, well, we can deliver virtual care or telehealth, especially for remote communities or populations that are not easily able to access healthcare. Any comments from a First Nations perspective with your work?
Yeah, that's right. I mean, I think those sort of technologies, telehealth, can contribute a lot to particularly remote health services plans in terms of reducing carbon emissions. There is a lot of travel that is involved in getting health professionals out to these very remote locations. Often they do rely on a locum workforce. So there is an incredible amount of carbon emissions just thinking about the transfer of health professionals across the country. So telehealth can potentially play a role in terms of making primary healthcare services out in the regions greener. But I've learned a lot from Zerina in terms of the other side of the technology and how it can also contribute to greenhouse gas emissions. I guess it's just finding that balance,
Yeah,
and also
that's right.
very encouraging to hear that AI can be trained to to improve technology in that respect.
Thank you, Veronica. Kelera, we might go to you with a different question, which I see has come up. And it's maybe there's a few different elements here to unpack. So the question is, the person asking the question would like to know if in Fiji you have the same problem as their country, where there's a change of government every 4 years, and so projects from the previous government to the next one may not continue. How have you managed to cope with that problem? And knowing a bit about Fiji, Kelera, you might say it's reasonably stable in terms of governance, or you might say there's some other factors that enable projects to continue and have this, really nice time span that you've described to us in your slides. Keen to hear your thoughts.
Thank you. Yeah, Fiji's governance is not that stable because we've just had a change in government 2 years ago, and it will be going for election again in another 2 years. So the transition for climate change and health work with the two governments, from my experience, has been very smooth because we had the commitments were already there, were already in place. The work on the adaptation plan had commenced from the old government into the new government, where we launched it last year. So if we have the contextualized versions of things that I had, instruments that I had shared today, this validate the existence of our work and the flow of our work. And it also it commits the position and not the person. For example, the minister committed into the previous initiatives, and then we give it to the incoming minister, even though these are two totally different parties coming in. And we just explain, and for the benefit of the people of Fiji and the health system in Fiji, it flows. It has not been affected by the changing government, except for a national document, which is the Climate Change Act. That is beyond my control as a health practitioner. Yeah. Thank you.
Thanks very much, Kelera. So you're talking about a fairly stable system then, where people seem, at least politicians, seem to be respecting the work that's come before. Is there a role? Can you tell us a bit more about the role of the individuals like yourselves and others across your climate change division and the health ministry? How have you worked together to make that stability happen?
Yeah, that brings our position and our own stability and the in-depth of how we had developed climate change and health within our own system and across the other sectors. So acceptability of what we are already doing by the incoming person may not be difficult, or if difficult, will still be accepted because of the progress that you can present to the incoming person, the achievements of the programs, of the project, of the guidance, and all the other initiatives that have been being implemented within the sector and across other sectors, and participating in regional and international forums is also important, because it also stabilizes your work and it grounds you in the work that you are doing and in influencing your political leaders.
Yeah,
Thank
great
you.
point. Great point. Thanks, Kelera. Yes. So the international developments are quite important for all of us to be aware of so that we can use that as a bargaining chip or a good advocacy point. Zerina and Veronica, any thoughts on that from your perspective and your...
I actually really appreciated Kelera. Oh, sorry, Veronica, you go first.
No, you go. No, you go.
Thank you. I really appreciated Kelera's work case study, because one thing that it reminded me of is how little we learn from other settings and how much more we need to do to actually promote these learnings to learn across the nations. I think we often lose out on not having these case studies more visible so that we can be developing new interventions and ways to move forward. Obviously, they will be adapted in a way that suits people, but it would be so nice to actually just build on that knowledge.
Yeah, I think a lot of learning, even in the Australian context. Thanks, Kelera, for your presentation, because we might like to think we have stable governance, but I'm not sure we do every 3 years, and how just how opposite, I guess, our two major parties are in terms of climate change and what they're willing to do to address climate change. So you feel like you do progress and then change a government, and it goes back a couple of steps. So yeah, thanks, Kelera.
Friends, we have about 3 minutes left to this session, and I should try to be a good chair and try to keep it tight. And I do have 2 slides to share with you. But Veronica, Zerina, Kelera, any final thoughts that you'd like to share from this session?
I just would like to ask the actual attendees to continue what they're doing beyond today, and to feel free to connect with us to share what we've learned and where we're going forward. Again, learning from Veronica and Kelera is really a unique opportunity for myself as well, but I can imagine that there was so much more to learn from all of you. So thank you for joining us too.
Thank you, Dr. Yeah, I echo what has been mentioned by Zerina. Thank you. I also thank the other 2 speakers, and also your facilitation of today's session, and all the participants who are listening in to us today. Thank you.
And my echoing of comments already just made. Adi, thank you so much, and yeah, please reach out if you want to learn more, and yeah, I'd be very, very keen to make some of the connections. I've been watching the chats and such a diverse range in the audience, so I'd be very keen to connect. Thank you.
Thank you all three of you for your expert presentations. I'll share my screen now and just put 2 slides in front of you all, and these are just QR codes just to make sure that you're familiar with where we are going next. Just please bear with me as I try to bring up my slides. Here we are. Okay, so we have here 2 QR codes for you. One is a WhatsApp group, and there's a separate one for China, which is a WeChat group. And here you can get updates and information about the course and from the planning team. You can also see some of these links in the chat section if you're not able to take a snap of this QR code with your phone. I will move to the next slide, so that may prevent you from taking a picture of this QR code, but it's another one to say we'd love to get your feedback from this post-session survey, and also there's a link to this in the chat as well. Just to echo also what Zerina and Kelera and Veronica have told us, that we're very keen to collaborate, and this collaboration, as you see with the organization's logos at the bottom of this slide, is really what makes a course like this happen. And we've heard wonderful stories from our colleagues at Columbia, GCCHE, which is hosting this set of sessions, that these kinds of discussions have actually led to some real implementation of projects in different countries, in different health systems around the world. So very keen to collaborate. I know all my fellow speakers will also be in agreement with that statement. So reach out and we'll be there. Thanks, everyone. I'll call this session to a close. Maggie, if you could just keep the chat open for a minute or 2, I might paste some content here as well with a link or 2. And thank you, everyone. We'll see you at the next session. Number 9 is the next one. All the best.